They give me the orthopedic lectures because I've done most of these injuries. And also I started my residency in orthopedics, but I wasn't smart enough, and so I switched out to emergency medicine. So it's always okay to throw yourself under the bus. Actually, that's not true. I became allergic to latex during my orthopedic residency in the early 90s, and I have to tell you, if you're doing a total or hip or total knee replacement, and all of a sudden you're like, and have an anaphylactic reaction, it doesn't build a lot of confidence, right? And if the anesthetist is spending more time with you than with the patient, it doesn't go over well. Anyways, I'm so excited to be here. You can probably tell by my pressured speech, because I love doing these lectures. And we do these lectures for practicing physicians that have been out 10, 20, 30 years. And I find that when I come to these boot camps, I got to sound Canadian there. When I come to these boot camps, boot camps? I don't know how you say it. Anyways, you guys are just like so into learning so much. Whereas when we're doing these review courses for ongoing physicians who have to practice some certifying exam, they're like, just give me the answer. Just give me the answer. I just got to pass this test every 10 years. You guys are like, yes, I want to know why. I want to know what I'm doing. I want to make sure I'm giving great care. So we're going to go through a half hour of how to do orthopedic exams, quick, fast, reliable, and chart them. So this is really, really important stuff, because who here sees anybody with a joint issue on a shift? Everybody, right? Don't raise your joint, please, really. No, everybody, right? I mean, this is bread and butter emergency medicine. If you're a clinician working in emergency medicine, you're seeing hips, knees, back, shoulders all the time. And so you have to have a really good approach to that. So I'm hopefully going to give you some super good pearls that you can take back to your own institution and be able to look like that Jedi Master. Oh, yes. When it comes to doing these exams, okay? So first of all, I've already put in it's a day in and day out thing. The thoroughness. It doesn't mean you have to click a novella. Click, 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 click. There's a study, I think, that says, maybe Diane knows, what is it, 3,000 to 5,000 clicks per shift, right? I mean, you're going to have click fatigue, right? Hyperclickopenia or something like that. You're going to be clicking your buttocks off. And so it's not about clicking a lot, right? It's clicking what you need to click, what you need to document. And while there are, Greg Henry's not here anymore, but while there are lots of big medical legal cases for misses in the emergency department for things like heart attacks and broken necks, because apparently society expects you as a ER clinician to pick up on those things. They broke their neck. They're having a heart attack. There's a big payout. But almost 10 times as many suits are filed with regards to extremity injuries. Hands, elbows, feet. And we see, and you know what? If you get sued, and I don't like to teach to the tort, and my Canadian system is much different than your US legal system, so I don't like to teach to the tort. But if you're going to be in the game, like your chances of getting sued, right? 10 times more likely that it's going to be one of these things. So let's get really good at these things so we just avoid the whole thing. It doesn't matter the payout. I'm going to be stuck for 3 to 5 years in misery. So let's get these exams done well. So not overcharting, not undercharting. EMRs are poor, not a big fan, and being really efficient at this. So I'm going to teach you how to be really quick, because a lot of times these things, these minor joint injuries, where do they put them? Fast track, right? And you've got to go a good, thorough physical exam, and you've got to document that and get some maybe imaging and get them out in a fast track situation. So I will sound like a broken record. For those millennials in the audience, that was a 12-inch vinyl thing that was pressed, and that's how music was generated years ago. I actually bought a record player for my 2 teenage daughters last Christmas, and they're like, thanks, Dad. They had no clue, right? And it was in the little suitcase, had speakers, and I bought them a couple of records to go with it. Like I bought them the Guardians of Galaxy, record, so I could go ooga chaka with them and dance, at night, in December. Anyways, they're like, how does it work? And I'm like, you put it on, there's a needle, it goes down, and they go, how do you go to the next song? Like, where's the button? I'm like, you lift it up, you move it over, and you put it in another groove. All right, it was a lot of fun. I'm going to sound like a broken record. You got to go the joint above and joint below, and there's really good reasons for that and great examples for that. So joint above, joint below, and you've got to check sensory, motor, neuro, vascular. You've got to check those things on each joint and extremities. And then skin. If you guys are throwing on some kind of a mobilization device, is this an open fracture? Do they have road rash? Is this going to get a pressure ulcer? So what's the skin look like? And then finally, the compartments, especially in the forearm and the lower leg. You got to make sure those compartments are okay before you start immobilizing them. All right, joint above, joint below. There are 3 examples on that upper right-hand side of the Italian boys. And it was Galeazzi, Monteggio, and Loprezzi. And those are the forearm fractures, those 3 Italian-named forearm fractures. And the reason we examine the joint above and joint below is because if you foosh, and everybody goes, oh, let's worry about the scaphoid, you also have to worry about the elbow, right? And if you fall on your elbow, depending on how you fall, you have to worry about the wrist because of the forces involved. So joint above, joint below, be systematic, be compulsive. I do not have OCD, okay? I don't. I have CDO. It's very similar, except the letters are in the correct alphabetical order, okay? And so you got to be compulsive about doing this. It's easy to chart, fast to chart, reliable. And if they give you an x-ray with a positive arrow sign, I'm really happy with my radiologist. I love it when they do that. If they could just add the diagnosis, that would be excellent, okay? But a positive arrow sign means something's wrong. And on the right-hand bottom sign, you see that fracture pattern down there. Does anybody know what that is? That fractured proximal fibula that could hit the common perineal nerve, that could give you foot drop and decrease sensation down the lateral part of your leg? It's not an Italian boy. It's a French one, yes. We're bilingual. It's a Maisonneuve, right? Maisonneuve fracture. And that arrow on the bottom is showing that medial tibial joint that you go over, and it's not an inversion injury, which we see the vast majority of the time. It's an inversion injury. All right, so let's go through the rapid hand exam, okay? First thing I like to teach people is name the digits, okay? Name the digits. Because if you put 1 down, if I'm in the States, you're number 1. I mean, you guys are number 1. You're number 1, right? But that's the index finger. If I'm in Europe or the UK, what's number 1 there? This is number 1. If you want another dumpling and you're in Asia, what's number 1 there? This. Right? Now, no country has adopted that, I think, as number 1. Is this being recorded? And I always remember that from that movie, Inglourious I'm not allowed to say bad words either. You know that movie with Brad Pitt where they're, World War II? And they ordered 3 more glasses of scotch. And they thought that they were American spies, but they weren't sure. And when they ordered 3 more glasses, the American went, 3 more glasses. Right? And in Germany, they would have ordered 3 more glasses like that. And that's how they knew they were spies. Okay? So name them. That's the thumb. That's the index. That's the bad one. That's the ring finger. And that's the pinky. All right? Name them. And then say dorsal volar. Don't say medial or lateral. I know that the ulna will always be on this side no matter where in space it is. So it's on the ulnar aspect or it's on the radial aspect. Talk about the snuff box and then give a description. Is it proximal? Is it distal to the IP joint, whether it's the DIP or the PIP? And then give a detailed injury assessment. All right, so you need to know all the nerves in the hand and how they work. So the 3 major nerves and know their motor and sensory function. You got it? Okay, good. What, you thought I was going to spend time on this slide? Look at this. This is an awful slide. Okay, so I'm going to give you a way to know what the nerves do, the 3 peripheral nerves that you need to know in the upper extremity. There's the median nerve, there's the radial nerve, the ulnar nerve. And if I go to you and say, and make you feel really nervous because I already came down and sat behind you already, and if I came to you and I went, yes, ma'am, can you please tell me the motor function of the median nerve? And you go, sphincter tone. I didn't know the median nerve was connected to the sphincter tone, but it's easy. It's the British nerve. Okay? Everybody got a cup in front of them? It's a British nerve. What does the median nerve do? It appositions, so it picks up the teacup. It's British. It flexes at the wrist. It's British. It flexes at the elbow, and it pronates. Oh yes, a little spot of tea. That's the median nerve. The rest is easy. All right, so for the motor function of the median nerve, it is the tea drinking nerve. It's British. Apposition, flexion at the wrist, flexion at the elbow. You could lead this. Yes, you could. All right, and pronate. All right, the radial nerve, you could consider it British as well, because it's stop. Or I'll say stop again. So it's the extensor mechanisms of the wrist are radial, and the ulnar nerve is the interosseous, okay, for motor function. Now, if you want to know sensory for cervical, and this is outside the lecture, C5 is here, right? C5 is here. This is 6. So it's 5, 6, 7, 8. You got that over there on this side? Oh, he's watching the screen. Okay, watch me on the screen, sir. Ready? 5, number sign 6, 7, I can do that now, and 8. Okay, so for sensory, right, for cervical, sensory. All right, hand exam. You've got the hand exam. Median nerve is the tea drinking nerve, right? Apposition, flexion, flexion, pronation. I've repeated it 3 times now. Okay, then when examining the hand, you want to know there's 2 flexors, right? There's the flexor digitorum profundus and superficialis. How do you remember that? Well, superficial is very superficial. It doesn't go very far. It's here at the PIP, proximal interphalangeal joint. Oh, but the profundus, it goes all the way. It's very profound. Yeah, I'm looking at you. It's like, oh my God, he's looking at me. Why don't you look at her? She was the one with the teacup. Yeah, exactly. Yeah, it's very profound. It goes all the way to the tip. And you can get the tip of the finger, and that's the DIP, the distal interphalangeal joint. And you're going to remember that. Look at her. She's playing with her hands. Hello, I'm very superficial. Sorry, I'm very profound. Okay? All right, so a few key nerves also, with branches off the 3 main nerves, is that for the ulnar nerve, right, that does interosseous muscles. So if your interosseous muscles don't work, you can't do that. But you also can get an ulnar nerve palsy, right? Like that's the ulnar nerve palsy. And where does that come from? There's a little history there. Back in the day when rabbis would bless the synagogue, they used to do it like this because this made a certain symbol, right? And then Mr. Spock, if you're a nerd like me, used to do this and say, live long and prosper. And when the first Pope came along, Peter, on this rock I will build my church, it's suspected that he had an ulnar nerve palsy and couldn't do the sign of the cross or the benediction. So from that moment on, the benediction was done with an ulnar nerve palsy hand, right? That's how I remember the ulnar nerve. Oh, whatever it takes to stay inside there. All right? So you've got a pure motor nerve with the recurrent median nerve. So the median nerve, what does the median nerve do? Show me. Tea drinking nerve, pince, flex, flex, pronate. Thank you, my dear. British. I should curtsy. Okay, so that's the British nerve. But it has a pure motor function, not sensory, right in here in your thenar. And so you'll waste away here, and you won't be able to do apposition, adduction, and flexion of the thumb, the oaf of the thumb. That is a big nerve to hit. You hit that nerve, in medical legal circles, they call that the $1 million nerve. I should do it this way, millions of dollars, right? Because if they're doing a carpal tunnel release for the median nerve and they nick the recurrent median nerve, you lose function of your thumb. And we took millions of years evolving to be able to do this as tool makers, i.e. Homo sapien, right? That's what Homo sapien means, tool maker, right? To grasp and do stuff. Now there's one pure sensory nerve, and that is the dorsal branch, the back branch of the radial nerve. That's on the forearm. It comes off right here. And so if you get a nightstick injury there, you get a plate glass window injury there, some kind of injury here, your wrist can still do this. And if you're documenting that the radial nerve is intact, it may not be intact because you may have hit the dorsal branch of the radial nerve that does sensation to the back of the hand. And if you want to know sensation, median is bump-diddy-bump-diddy-bump. So here, thumb MTP, or MCP, thumb MCP, this is median nerve, bump. This is radial, bump. This is ulnar. So you can do this quickly. Bump-diddy-bump-diddy-bump. Sensory intact. Median, radial, ulnar. Median, radial, ulnar. But if you hit the dorsal branch of the radial nerve, you can do this, but you can't feel this. Okay? So that's the detail we're looking for. All right, and there it is showing the thenar muscle for the for the recurrent branch of the medial nerve, and then the dorsal branch of the radial nerve. All right, some special physical exam tests that you can do at the bedside when examining the hand. There's a Froment's palsy, and that's the test where you get them to hold a piece of paper, and you get to hold it tightly. So if you take a piece of paper and hold it tightly, people will go like this with a flat thumb, right? But if they've got an ulnar nerve injury, because remember, ulnar nerve does interosseous on the thumb, the median nerve, what's it do? Right, my British friend. Yes, and so they'll hold the piece of paper like this with the thumb up. Do you need to zoom in? I'm talking to the tech guys. Ooh, unnecessarily closed up. Yeah, so instead of like this, they'll go like this, and that's how you identify that they have an ulnar nerve injury, motor, by doing that test. Phelan's sign, or test, you know this, right? When we're testing the medial nerve, and then you can exaggerate it with a modified Phelan, just to compress that median nerve to get that numbness and sensation in these digits, right? And then Tinel's test. Everybody thinks Tinel means tapping at the wrist. That is the median Tinel's test. Tinel, named after a physician, was just the tapping of the nerve. So if you could tap, 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 tap there, looking for carpal tunnel syndrome, and they go, yeah, doc, yeah, that's what it does, okay? Gives me the But if you tap here on the ulnar nerve, right, that's a Tinel test at the ulnar nerve, and that'll give tingling in the ulnar nerve distribution, right? Remember that one, right? So the ulnar nerve distribution. And we also call that a Saturday night palsy because you pass out. We could call that a vagus palsy. You pass out on your ulnar nerve, and then you wake up and your hand's all numb, and it's in the ulnar nerve distribution because you've been putting compression on the ulnar nerve. Or you've got your hand around your partner and you're watching a 3-hour movie and then your hand goes numb. Same thing. Snuff box, you know where that is. Finkelstein's test, that's where you put your thumb in like this, wrap your fingers around the thumb, and pull like that. What does that tell you? Does anybody know that? Shout it out. Dequiverins, yes, tenosynovitis. And we're going to talk about the difference between dequiverins and Oersmann, okay? And that's like dequiverins is regular boot camp, okay? Advanced boot camp is Oersmann's. All right, so we'll talk about that. And then the East test, they've got great YouTube videos on this. This is looking for thoracic outlet syndrome. And you go like this. Na 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 na. No? Yeah, actually you just do this. So you go like this for 3 minutes. And your hands can go numb, right? And that's looking for thoracic outlet syndrome. Thoracic outlet syndrome. It's the East test. 3 minutes like that. All right, dequiverins tenosynovitis versus Oersmann's. So where you wear a wristband, watch. If you have pain with Finkelstein's doing this, right at the base of your thumb. At the base of your thumb, that's dequiverins tenosynovitis. If it is proximal to that, on this side of where you wear a watch, that's called Oersmann's syndrome. It's different. Oersmann's is still a tendinitis, but it used to be from people rowing. We don't have a lot of rowers in our society now, but we do have a lot of laborers who swing sledgehammers. So if you see a patient and they're complaining of pain, right, with movement, and you do the Finkelstein's test and the pain is up here, you can go, oh no, that's not dequiverins. I took advanced boot camp, ABC, and that's not ABC dequiverins, that's ABC Oersmann. Okay, that takes you to the next level. There's some other there with keyboard thumb and all that kind of stuff. All right, one of the key concepts is if you're getting x-rays or imaging on these individuals, and you're like, I'm pretty sure they got a fracture, and I was surprised to get the images back that didn't show a fracture. X-ray technologists love this. Can I get one more view? They have all these different views besides the, oh, that was the AP, the lateral, and the special view that they have. Let's say for the ankle, where they've got the mortise view, right, where they turn it in and get that joint line. There are other views that they know about. And if you don't see the injury, you could say, can I get one more view, please? So we've got a tunneling view of the wrist, which shows that arch of the wrist bones. We've got some nice arrow signs on the knee there. The one on the right-hand side where there's a blue thing shooting down, right? That's a special view looking for calcaneal fractures called a Harris view. And I've used that quite often when I said, listen, I just don't see it on the AP and the lateral. Could I get a Harris view? And all of a sudden the tech's like, ooh, You're talking my language. I like this. Okay, there's a radial head view where they do specifically to isolate the radial head because they can be occult fractures and hard to see. So just ask them for one more view. Can I get a specific radial head view? And then the one on the arm there is looking for an anterior versus posterior dislocation. If you can't figure it out based on the films you have or the digital images you have, you can get an axillary view. So just that concept of, hey, do you know one more view? And if your spidey senses are tingling, I'd like one more view, please, and take a look. Now, there are some missed injuries that we don't want you to miss because you're at the advanced boot camp. The ones that, like everybody gets all excited about, oh, we're not going to miss a snuff box scaphoid fracture, right? Avascular necrosis of the scaphoid. So people are always really tuned into that. But the most common injury is for a slack wrist. And we'll show you where those are and tendons. So you've got flexor tendons, you've got extensor tendons in the wrist, in the hands. It's interesting in the hands for the extensor tendons and the fingers. It's really, if you put your hand flat like this. Yeah, I'll wait. It wasn't a request. No, okay, try to lift up your index finger. Wasn't that easy? Try to raise your pinky. Isn't that easy? Try to raise your ring finger. That's hard, isn't it? Because there's only one extensor, usually, for your ring finger, whereas we've got two extensors for this. So if your extensor mechanism is intact, one out of the two, the extensors may be out. So you need both intact. You can get movement with only one intact, but not so with the ring finger. It's only usually got one. Things like that, especially if you're going through things like people with anger management issues, usually I'm having a quiet drink with friends, but there are other people who actually punch through windows and walls. They sell these things. Do you guys have Home Depots down here, stuff like that, those hardware stores where they have the stud finders, right, where they, you go along the wall to try to find the stud where you're going to put the screw in for the drywall? You just need a teenage boy, right? Just punch the wall. They'll find the stud, right, and they'll come in with a boxer's fracture. And I shouldn't be gender specific that way. All right, missed ligamentous injuries. This is the slacked wrist I was talking about. Scaphoid lunate ligament injuries. So the scaphoid and the lunate in the wrist, where the scaphoid comes together. The scaphoid is the biggest articular surface in your wrist, and it's right up against the lunate. And if you get a foosh and you read the x-ray and you put down their sprained wrist, make sure you've checked that they don't have a scaphoid lunate dissociation, that it's not spread out. And there's an x-ray down there on the right-hand side. And even in that small image, you can see there is this big gap. It's usually described as more than 3 millimeters. But look at all the other joints in the wrist and how they overlap and fit. And yet there's this big glaring black spot between the scaphoid and the lunate. Do you see that? Okay, so let's age-ize the audience. Who knows what that's called? Terry Thomas sign, yes. So you're over a certain age. Sorry, you've revealed yourself. You look so youthful, though, right? And now if you're of my generation, we call it the David Letterman sign, right? It's the big gap there, like in his teeth that he had. Now we need something for millennials. I don't know. There must be some celebrity that has a big gap in their tooth or something like that. But we used to call that the Terry Thomas sign. Now we call it the David Letterman sign. Come up with something new. Tell me. We'll put it out on Twitter. We'll get a hashtag going, okay? All right. And then, of course, they've got the lateral collateral ligament there. That's the ski pole thumb. So you're skiing and you have a sudden extension injury to your wrist or to your thumb while holding a ski pole, and you get that ulnar collateral ligament right there, and you can get a ski pole thumb, and you'll get a little avulsion, and that's what the positive arrow sign is for, a little avulsion there. Tell you about that injury. All right, so you guys have been. This is day 2 or 3. 2. So are you comfortable enough turning to your neighbor and touching them? It's Vegas, baby. I won't tell anybody. All right? So turn to your neighbor, all right, and feel for their ulnar style. I'm expecting you to do this, people. Turn to your neighbor. Hi, introduce yourself first. You should be on a first-name basis, maybe. All right? Oh, look at that. They're making friends. Oh, did you guys know each other before you came to Vegas? Oh, you're going to know yourself after. Okay. So all you do is feel the ulnar styloid. You feel the bump. It's not the big bump on the radial, right? The ulnar styloid, the radial styloid. My mistake there. The big bump you feel, ulnar, that's the ulnar styloid. I want you to feel the smaller bump on the radial aspect. That's the radial styloid. You feel that on your partner? Go towards the ulna, and you'll hit a ridge. That's Lister's tubercle. That's an important landmark. You go distal to that, you drop into the wrist joint. And if you are ever going to aspirate a wrist, this is where you stick the needle in. And this is where you're checking for a scaphoid lunate dissociation and pain. Okay, so feel it on your partner's wrist, have them feel it on your wrist, and then feel it on yourself. Okay, but it's always better to play with someone else. All right, and so feel the radial styloid, go ulnarly towards that Lister's tubercle, and then drop distal into that joint space, and you feel that right in there. And that's where you're going to get that scaphoid lunate joint. All right, some x-rays here. For a Fuchs injury, you can see they've got some positive arrow sign. The red arrow is showing the tricutrial fracture that's often missed because you don't pick up that little flake off the back. That's the most commonly missed avulsion fracture in the wrist. So they're easy to miss, and you can't see it on the AP. You only see it on the true lateral. Okay, so that little fleck there, get you into trouble. And then scaphoid fractures. And I know you guys have been doing scaphoid, and everybody's always worried about it, and you fooshed, and if it's a clinical scaphoid, you have these different algorithms about immobilization. Just to tell you that if you get plain films, and you know this, if plain films would rule out a scaphoid, we wouldn't be putting people in immobilizations and having them come back or going for CTs, right? If 6 views of the scaphoid could pick up scaphoid fractures, we wouldn't have this diagnosis called clinical scaphoids. Right? But I want you to warn you that if you get a CT scan and it shows no fracture, that doesn't mean you've ruled it out. The only test with a negative likelihood ratio, i.e. less than 0.1, a negative likelihood ratio good enough to rule out a scaphoid fracture is an MR. Now, in some places, that's not going to be possible to get an MR. But there's some MRs to show you, and they won't necessarily show up on CT. So plain film's great for ruling in. If you see it, you've got it. If you don't have it, you're going to have to immobilize, or you're going to have to go to CT. If the CT shows it, you've got your answer. If it doesn't show it, that could still be a fracture, right? And remember that scaphoid has the largest articular surface in your wrist, so you want to make sure you diagnose that. And then we have the paralunate and lunate dislocations. I think I have a pointer. Now, where do I point this? Do I point it at the screen, Jim? Anywhere? That didn't work? Do I just point it like that? Anywhere? No. Do I point? What do I do? Do I point like, I don't know. Yeah. All right, so you've got a lateral of the wrist. You've got your distal radius there, right? And you see the lunate in that middle image. That middle image, the lunate is sitting tipped forward, and the capitate is back and off. Do you see that? We call that distal radius C1. It's a C structure, C1. The capitate is supposed to sit in there. That surface is called C2. The distal surface is C3, and then the capitate surface, proximal surface, is called C4. So C1 is supposed to be talking to C2. In that middle image, it's not. And also, C3 is not talking to C4. So the lunate is dislocated. That makes sense to me. The perilunate dislocation is that lateral image, that right-hand side image, and you can see the distal radius and the lunate is sitting there, right? You see the lunate sitting there in the cup, right? But they call that a perilunate dislocation because it's actually the capitate that's off. It's peri, it's dodged, it's beside, right, where it's supposed to be. So it's really a capitate dislocation, but we call it a perilunate dislocation. And it's really hard to see these sometimes in your lateral x-ray. So you got to put your mind and go, C1 is talking to C2, C3 talking to C4. Is everything lined up in that axis? All right, lower extremity injuries. All right, these are usually easier, except for knees, because we've got the internal derangement of the knee. They can be difficult sometimes. If it comes to a hip question and you're like, geez, you know, the patient just can't get up and walk, and they've had a fall, and you can't see on plain film, you can't see on CT scan a fracture, they can have occult fractures, and sometimes it takes an MR to pick up on those subtle fractures of hips. So if they can't walk, they can't go home, usually. All right? Ankles, we'll go through some lesser-known injuries. Again, it's the joint above, joint below. Check for their motor, sensory, and vascular status. Look at the skin. All right? Ankle fractures. So There's a whole bunch of different ones, but when you're looking at an AP, you've got your tibia, your fibula, your talus, and then you're looking for fractures along there, and we'll talk about some of them. So that mini tour of the ankle here and the foot, that middle image, anybody know what a fracture at number 1 is? I'll give you a hint. Ready? The number 1 is? Yes, a dancer's. Thank you. Thank you very much. All right. Number 2, anybody know what that is? It's not a Smith. Jones fracture, yes. Okay, so you got a dancer's fracture at 1, which is an avulsion fracture of the 5th metatarsal. You got a Jones fracture, which is in that transition zone, and then in the mid-shaft you have a fracture. Okay? Number 3. And then there's all these subtle fractures along that area. Talar dome fractures are hard to pick up. I had one of those talar dome fractures, and it was missed on me, and it wasn't shown until I got a CT scan. And then you've got these ossicles, these ossification centers around the foot, and the one that's most often diagnosed as a fracture is the os trigonum, which is the one in the middle of the screen that says os trigonum, which is in the back of the ankle there, and we call that os misdiagnosum. Okay? So this is how to, not only do I want you to look like Jedi Masters and superstars, I also want to avoid you going, os misdiagnosum. Right? Okay? So that is, now you can fracture that. If it's big enough, you can fracture through it. Then we've got a few flex signs. This flex sign is where you pull off the avulsion of a Liz Frank fracture and the spreading out of the first and second joint, right, on the foot. It's usually seen by motorcycle riders. They put their foot down, and it gets splayed like this, and they get this joint injury. This is a serious injury, and it's hard to pick up sometimes. Sometimes it's just the subtlety of, ooh, it looks widened. I don't know what it's saying, but it looks widened, right? Look for that little flecker, all right? And if you see that, you've got a fracture there. Here's another flecker. Notice how I didn't put another word in front of that. But that little arrow sign on the lateral aspect, that's called a Scaphoid fracture. Oh, you would look awesome. If you saw someone who twisted their knee playing soccer and you thought, oh, I think they blew out their ACL, and then you point out to the radiologist, oh, what's that little avulsion? Is that a Scaphoid fracture, doctor? Oh, you look like a star. Yeah, because that almost always, about 75+% of the time, will mean that you've done the ACL if you see that avulsion fracture off the lateral aspect. And then we're going to finish off with a few back things, and back's a big deal, but just a few back things. First of all, take the shirt off. You actually have to look at the back, okay? It's omission, not commission, right? You didn't actually look. If they're complaining of back pain, who here has done this? Where they said, oh yeah, I saw somebody yesterday, my back was killing me, and you lift up the shirt and go, ooh, that's a shingle, right? And nobody actually lifted the shirt up. So actually look. And then we have something called tuna fish from my friend Salim Razai, and I'll talk about those. So tuna fish stands for trauma. So if they have trauma to their back, they need imaging. Unexplained weight loss, that's getting at cancer and other things. Neurologic symptoms, saddle numbness, okay? Saddle numbness, pain below the knee, some kind of neurologic symptoms. Age over 50, great. I'm in that category now if I have back pain. Fever, spinal epidural abscess. IV drug use, lots of people out there. Steroid use, I put diabetes in there because they're, diabetics. And then history of cancer, because you're looking for serious back problems. And if they're presenting with any of these red flags, you should be concerned in getting more advanced imaging. So undress them, feel along there, check for it. And then reflex testing of the lower extremities. It's 1, 2, tie your shoe, 3, 4, kick the door. Okay? 2, 3, 4 keeps the poop off the floor. That's the S2, 3, 4, by the way. So it's 1, 2, tie your shoe, 3, 4, kick the door. If we want to finish it, it's 5, 6, pick up sticks, 7, 8, close the gate. Those are your deep tendon reflexes. Everybody get that? 1, 2, tie your shoe, 3, 4, kick the door, 5, 6, pick up sticks, 7, 8, close the gate. Reflexes. Easy. Okay, straight leg tests. Okay, lift them up. The pain has to go below the knee. You guys know straight leg tests. If you do it to the other leg, that's actually a bit more sensitive. And post-void residual. If you get a CT scan like that, it's like, oh, where was my bedside ultrasound? How did I order that? Okay? So a big, big bladder like that, if you've got urinary retention, you're worried about spinal epidural abscesses, cauda equina syndrome, it's urinary retention. Now, they may come in saying frequency and get diagnosed with a UTI. That frequency is overflow. and they've got that big mass. Lift up the shirt, feel, get out your bedside ultrasound if you want, and urinary retention should have less than 250. That's it. Thank you very much. Appreciate it.